or duration of stay at Cullinan Wellness Hospital, our patients and their loved ones can rest assured that they will be taken care of and watched over by our team of experienced mental health nurses, psychiatrists, and clinical psychologists.
Most of the patients that we admit are voluntary patients and they come on their own. The diagnosis that we normally work around is that patients with bipolar mood disorder, major depressive disorders, as well as post-traumatic stress disorders. Some has personality disorders such as gambling.
Our hospital provides private psychiatric services that aim to help the individual experience the fullness of life. We cater for a wide range of patients, including those with depression, bipolar, post-traumatic stress disorders, anxiety disorders, sleeping difficulties, neurocognitive disorders, dementia, and psychiatric conditions, amongst others.
My approach is I use what we call cognitive behavioral therapy, CBT. So basically it's helping, because most of the time I've noticed that we tend to be depressed or go into mental problems because of the channeling of our thoughts. We tend to think, if you are going through a difficult situation, you tend to think more negative about it than thinking positive about it and actually getting a solution. So I just help my patients to come up with solutions, and hence I use solution-focused therapy, because I'm confident that they do have solutions. It's just that sometimes they're not confident to put them into action.
My approach when treating a patient goes back to the good old Pathophysiological principles. We follow a very client-centered approach. Every case is different, and so applying Pathophysiological principles where it's about the patient, it's about dignity, it's about ensuring that the patient's needs are met, is at the core of practice, is at the core of all intervention.
As mental health practitioners, we encourage individuals to visit our facility so we can assist them in finding routine solutions to the problems they face on a day-to-day basis.
I think from a very simple point of a non-functional mind is a non-functional human, and neglecting mental health means, in essence, neglecting a whole part of yourself that is very necessary to maintain function on a day-to-day. The more we ignore the brain and the psychology and the emotions of a person as we have been, the more we are likely to not reach to the full potential that we could.
At Clinics Cullinan Wellness Hospital, we believe mental health is the cornerstone to helping you find and lead a happy, balanced life. Visit our magnificent facility at Hospital Road, Cullinan, Pretoria East. We're open 7 days a week and are ready to receive you.
Thank you very much, Zuki, for that wonderful presentation on Cullinan Hospital. It's our wellness center outside Pretoria. And this week we've heard about tragic events concerning the recurrent. We know that mental health is on the agenda now because of that incident, and we hope that we'll be engaging more on this so that at least members of the public are quite aware where they can get help in terms of mental illness and depression. And so that's why we also want to show this center that we have in Pretoria is the Cullinan Hospital. And thank you very much and welcome to our webinar this week. We're excited to have you back once more at clinics as we continue to engage the healthcare sector and also to be one of the thought leaders in terms of healthcare delivery and public health in our setting within our region. And this evening, we also want to welcome all those who have been our regular attendees and the new ones who are joining us today we want to say thank you for showing confidence in the type of information that we share on this platform. And just as a reminder that when you do log in, please remember to switch off the video and also mute yourself so that we maximize the data reception for the presentations as we invite our speakers to talk to us. Note that this webinars are CPD accredited. With HPCSA, we get CPD points, 1 CPD point for an hour. I know that there's a time when we went beyond an hour and people are saying, why don't we get 2 CPD points? But we'll look into that. And so please make sure that when you do register, you provide all your details, name, surname, contact numbers, and also your registration number with HPCSA, because we know now we don't have to send, you don't have to send your information to the HPCSA. That information we submit it and it's logged in, and automatically you get your CPD points once the information has been forwarded to the HPCSA. For those who are in Nursing Council, we give a attendance register, and you will be able to then submit your points to the council. And if if it is the practice, they will also give the CPD points per their arrangements. And this evening we have one of our speakers. He makes a second visit. We had him sometime last year, Dr. Russel du Toit, who's a vascular surgeon. He's got a degree, MSHB from the University of the Free State, and fellow of the College of Surgeons, South Africa, and the CVS Cardiovascular Society, South Africa also. He's currently practicing at Dr. SK, one of our centers in Diepkloof, Dr. SK Maseki Memorial Hospital. And prior to joining us, he was a general surgeon in Kimberley. And she was consulting there, operating at Kimberley Hospital since 2011, specializing in both general and emergency procedures. Dr. du Toit, as I mentioned, he's got an MBC from the Free State, and he's interested in vascular surgery and performed arterial venous fistula procedures for dialysis. And I think that's why we want him to work with our nephrologists within the group. And so tonight he's speaking to us on the acute limb ischemia. And so Dr. du Toit, we welcome you once more back to talking to the colleagues here. And we're looking forward to quite an interesting discussion as we did the last time when you were with us. And please do everybody just a reminder that these webinars are recorded on YouTube, and we'll give you a link where you can access the recordings after the presentations. And thanks, Dr. du Toit, welcome. You can unmute yourself, Doc, and share your screen.
Are you still with me?
There you are. Yeah, I can see you. Now we need to see the presentation.
Can you see the presentation?
Not as yet.
Okay. Sorry.
Not as yet. We had it the last time when we tested earlier on.
Yeah, I'm not sure what I did yet. Sorry, I'm a bit.
Hi, Doc. You can click on the share screen option.
Okay.
Bottom of your screen.
I've totally lost the
Presentation.
share screen. Yeah. Can you see it?
Not yet.
Okay.
Yeah, there's coming.
Yeah.
Sure. Thank you. We've got it. So you can just go to slideshow, and then we are on. Great. Yeah, we've got it.
Right. Good evening, everyone. Thank you, Dr. Bila, for the opportunity to present to you again. I hope to discuss, a topic that's quite important to us as vascular surgeons, acute limb ischemia. Important that we see a lot of people, who present with this condition, and they often present, very mortality to it. So, thing that I can convey to you, I think for a lot of people it will just be a bit of revision and a bit of touch up, on the principles around it and how we manage it. So this is just the overview of the talk. We'll be discussing on those aspects, and hopefully at the end I can just give one or two summary points and then open for any questions. So if we look, how one could define acute limb ischemia, so we look at it as a sudden reduction or even a complete cessation of arterial perfusion to a limb, which subsequently then is either limb that previously even potentially life-threatening. And it normally occurs within after the onset of symptoms. Looking at some of the epidemiological aspects, studies from the UK and Sweden suggest that there's an incidence of around 3 to 14 per 100,000 person years, and most affected by this condition tend to be elderly patients, so advanced years, 75 over. Although having said that, we have seen with this COVID pandemic, we've seen a much younger group of patients also presenting with acute symptoms. Data from the United States Medicaid over a 10-year period from 19 to 2009 showed that there was actually a decreasing incidence of acute limb ischemia admissions. They also noted from their data that the number of open revascularization procedures for acute ischemia had declined by about 5%. And that was probably due to the increase in the use of endovascular techniques in this condition, and we'll expand a bit more on that a bit later. Also, what they noted was that there was a decrease in the amputation rates from about 8 to 6.4%, and also notably a reduction in the in-hospital mortality for these group of patients from around 12 to 9%. So generally, a sort of a good trend for this group of patients. And the thinking is that this was probably due to an increased use of the thrombolytic therapy for acute limb ischemias, and also the increased use of endovascular techniques to treat this condition, as I pointed out. Also, they think that the overall improvement in the seeing less admissions and seeing less amputations and a reduction in the hospital mortality was also due to an improvement in the detection and early treatment of conditions like atrial fibrillation and atherosclerosis, which we know are very important risk factors for developing acute limb ischemia. So there have been some trials done looking at acute limb ischemias. Notably, the 3 trials that we are aware of are the Rochester, the Topaz, and the Stilly trials. I quoted here the Stilly trial, which was a randomized controlled trial of 393 patients, and it basically compared open revascularization to thrombolytic therapy using either recombinant TPA or urokinase. And what they found was at the end was that patients who presented early, so those patients who came within 14 days of symptoms, they had a better or a much better amputation rate at 6 months if they underwent thrombolysis, thrombolytic therapy. Patients who presented later, so after 14 days, after 2 weeks, those patients did better if they had open surgical revascularization. So just something that maybe, sort of echoes the findings here of, an increase in the endovascular technique and also a reduction in amputation rates. So what they've noted also over the last century was that there's been a shift in the etiology of acute limb ischemia. So previously, it used to be a condition found in young patients. So patients that presented mainly with embolization from rheumatic heart disease and valvular heart disease. And there's a group of patients that we now see more often, being the elderly group of patients who present with embolism mainly from arrhythmias and also due to thrombosis of atherosclerotic blood vessels. So the main causes, as most of us know, is either embolic or embolization, and this is mainly due to atrial fibrillation or an atrial or ventricular thrombus, which can complicate an acute myocardial infarction or decompensated cardiomyopathy or decompensated cardiac failure. Acute thrombosis then is also the other main cause, and this tends to occur in very atherosclerotic arteries. The time to presentation, so most patients, 70%, present within 2 weeks, and then the remainder, 30%, present after 2 weeks. So these are our most common causes, as we pointed out, embolic or embolism, and most of the embolism arises from the heart. So 80% have a cardiac origin. The other sources of emboli are then mainly from the more proximal arterial beds, so where you've got extensive arterial plaque, or where you have aneurysm thrombus, as we sometimes see with abdominal aortic aneurysms. Sometimes these patients present with embolic phenomena as a symptom of the aneurysm. The other main group of causes then are the thrombosis. And as we said, this can occur in native arteries that are very atherosclerotic. You can get thrombosis from peripheral aneurysms, and the notable aneurysm that's a cause here is a popliteal artery aneurysm. And we also see then thrombosis of previous vascular bypass grafts or previous endovascular stents. Other causes of acute limb ischemia we sometimes see in the setting of acute arterial dissection, where it causes malperfusion to various structures, either within the abdomen, in the visceral arteries, causing intestinal ischemia, or causing peripheral limb ischemia or renal ischemia. The other main group of causes are then obviously the traumatic groups, and We see this with both blunt and penetrating trauma. Commonly, blunt injury due to knee dislocations, what we see, and then also various mechanisms of penetrating, either stab or gunshot wounds. Other group also that we sometimes encounter is the iatrogenic group, where this is mainly due to injury of the arterial system due to attempted catheterization procedures, and then also due to surgery that occurs in close proximity to various arteries. So some data from the Swedish vascular registry from 2018 shows that they had a total of about 16,000 patients that presented with acute lumischemia, and of that group, 44% were embolic, 53% were thrombotic, and 3% presented with complicated popliteal aneurysms. The embolic causes, as we said, are mainly due to cardiac dysrhythmias. The main culprit there being atrial fibrillation in 67%, and then ventricular thrombus, either following an acute myocardial infarction or cardiac failure. And also still, they note that valvular heart disease is still an important cause in the low to middle income group countries. Less common causes of acute lumischemia are various forms of vasculitis, and here the common ones that we see are Berger's disease, or otherwise known as thromboangiitis obliterans. We also see HIV-related vasculitis, the connective tissue diseases, rheumatoid arthritis, SLE, Takayasu's, and nowadays the new kid on the block, the COVID-associated vasculitis. Thrombophilias of various causes also lead to acute lumischemia. Commonest ones we see are protein S and protein C deficiencies, antiphospholipid syndrome, and then also the thrombophilia associated with COVID-19. Very rare causes are the popliteal arterial embryological conditions, popliteal adventitial cystic disease, and popliteal artery entrapment syndromes. Paradoxical embolization, where you have a venous embolism that passes through a patent atrial septal defect or patent foramen ovale to end up in the arterial bed, and so causing acute lumischemia on the arterial system. Tumor embolization from intracardiac tumors, for example, atrial myxoma. And we actually had a patient who presented with this condition in 2015, a young male patient presented with acute lumischemia of his left leg. And when we went looking for a source for the embolism, we found that he had an atrial myxoma, and he was subsequently referred for cardiothoracic surgery. We also sometimes see this in acute compartment syndromes. This is mainly found in athletes who've got well-developed leg muscle groups, and they develop this after quite intense exercise. Low cardiac output states, as we said, decompensated heart failure and septic shock. So the pathophysiological mechanisms are really quite self-explanatory, and they basically arise as a result of acute onset of tissue hypoxia. So remember, the main problem in acute lumischemia is that this is important. There's no collateral circulation. So your body hasn't had time to adjust to the ischemia, and this is what makes this acute setting imminently limb threatening. So your your peripheral then muscular beds then undergo anaerobic metabolism. You have generation of reactive oxygen species. You have lysis of the cells, liberation of the intracellular components, which leads to tissue swelling, tissue edema, and onset of compartment syndromes. So clinically, how do these patients present? Well, the 6 Ps are what one should bear in mind when we look for acute limb ischemia. So these patients present with pain, sudden onset of pain in the leg or the arm, and they can often localize the onset of the pain very well. So patients will often tell you, I had onset of severe pain in my leg at 8 o'clock last night, and it's just become progressively worse. So well localized onset of pain. The leg appears pale, it's cold, pulseless, and in the more advanced ischemias, the patients have paresthesias distally on the leg, on the arm, and in even worse cases, they present with paralysis and paresis of the limb. So this is just some clinical pointers to whether you're dealing with an embolic or a thrombotic cause for the acute limb ischemia. So the embolic ischemias tend to be more rapid onset. So they have a rapid progression over a period of hours. The thrombotic occlusions tend to happen more gradually. So they have a more gradual onset, and their progression tends to occur over a period of days. And as we pointed out, cardiac abnormalities are common in the patients with acute limb ischemia, and in the thrombotic group, it is often not that common. The embolic group often don't have claudication or pre-existing claudication, and the thrombotic group generally tend to give a history of having had claudication. In the embolic group, there are no dystrophic leg features. In the thrombotic group, they often have signs of underlying chronic ischemia of the leg. So they may have muscle wasting, muscle atrophy, and so on. On further examination of the leg, you often find the palpable femoral arteries in the groin to be soft in the presence of an embolus. And with a thrombotic group, they often have hard calcified vessels indicating the underlying extensive atherosclerosis. Contralateral leg pulses generally tend to be preserved, or contralateral limb pulses are generally preserved in the embolic group, and in the thrombotic group, more often than not, they tend to be absent. There's just some clinical pictures. You can see there the obvious pallor on the acute limb, and on the bottom on the left, you see a patient. He's got quite advanced ischemia. He's got extensive mottling, and his leg is more than likely not salvageable. So how do we grade acute limb ischemia? So there's a classification system called the Rutherford classification system, and it grades the ischemia into 3 groups. So grade 1, in which you have a viable leg. Grade 2 is subdivided into 2A and 2B. 2A indicates a marginally threatened limb. 2B indicates an immediately threatened limb. And 3 indicates a non-salvageable or irreversible ischemia. And then there are other signs that one looks for to indicate the grade of ischemia. In terms of prognosis, generally the grade 1 limbs tend to have a good prognosis, as well as the grade 2A limbs. The grade 2B tends to have a guarded prognosis, and the grade 3 tends to have a poor prognosis. And in almost all circumstances, they require amputation. So when one approaches these patients, it's probably a good idea to look at, benefit versus harm. So when deciding, is it worthwhile to revascularize this patient's leg or to attempt to revascularize a patient's leg, or is it going to subject the patient to further harm, which could, sort of precipitate a second hit phenomena that pushes the patient over into, a very poor outcome. So there we look at, at various things. You look at the patient's age, what is their operative fitness, what is the extent of their underlying comorbidities, what is their current quality of life, and what is the expected quality of life in the relatively short to intermediate term. And then also one looks at, what intervention can be done or what interventions can be done for the patient. And taking all of those into account, one then has to give the patient, and preferably also the patient's relatives, give them, all the clinical findings and the clinical information, and, to help them decide on what they would prefer as a course of treatment. So looking at the initial management of these patients, so it mainly involves around instituting medical treatment for these patients. So, it may sound like, very trivial interventions, but a lot of patients can be stabilized quite substantially with just doing this medical treatment or instituting these measures. And I must say, from what we've seen, a lot of these measures are actually not even considered or even done for patients that have presented with acute ischemias. So supplemental oxygen, you want to improve oxygen delivery as much as you can. Good analgesia, these patients have already underlying cardiac diseases, and you don't want to precipitate any untoward cardiac events. Have the patient feet down just to try and have gravity assist with improving the perfusion. Instituting use of an antiplatelet agent such as aspirin, 300 milligrams as a stat dose. Also starting a statin and anti-inflammatory medication, simvastatin, 40 to 80 milligrams per os. And then also using unfractionated heparin. Now I'll discuss a little bit more now about unfractionated heparin and why we prefer unfractionated heparin over low molecular weight heparin. You give a bolus dose, a stat dose of 70 to 100 international units per kilogram. And then you can put the patient on an infusion and try and maintain the patient's APTT around about 90 to 120 seconds, which is about 1.5 times the normal range. You then grade the patient's ischemia and also assess the patient's response to the above treatment. And if you need to refer the patient out, also timeous discussions around referral of the patient. So as I said, why do we prefer unfractionated heparin? So heparin, basically the use of the heparin is to try and prevent extension of the thrombus or propagation of the thrombus. Unfractionated heparin is a larger molecule than the low molecular weight heparin, and therefore it's able to bind more clotting factors. It can bind antithrombin 3 and 9, as well as activated factor 10. The low molecular weight heparins are very much targeted on activated factor 10. It also, unfractionated heparin also has a pleiotropic effect in the sense that it seems to exhibit an anti-inflammatory response in the arteries and therefore reduce spasm and help to improve what little perfusion there may be. Also, the other advantage from an anesthetic and a surgical point of view is that unfractionated heparin can be rapidly reversed by using protamine sulfate. So protamine sulfate can be given, and in those doses as stated there, based on when the unfractionated heparin was given. So this is just an algorithm. I won't really go too much in this. I will discuss a little bit of an algorithm a bit later on, which may be a bit more simpler than this one. So the new thing in treatment of acute limb ischemias is that it has been found that imaging these patients are extremely important. You need to have some kind of idea of what is happening, in the arterial system. Where is the occlusion? What is the extent of the occlusion? And that, is what helps you to determine what can be done for each particular patient. So imaging is very, very important. And according to the guidelines that we follow for acute limb ischemias, CT angiogram is recommended as the first line imaging modality to assess the extent of the ischemia. And then the other thing is where to treat these patients. So in the ideal setting, these patients are treated at a center where they are able to undergo a range of treatments that may be required, ranging from endovascular interventions to open surgical interventions. So, if these patients are at all able to to be referred to such a center, it would be advisable, because it makes the management of the ischemia a lot more simpler, and one can use the more sort of endovascular type of procedures that are coming to the fore if one has access to either a hybrid theater or have a C-arm available with the in theater. So what sort of interventions are we able to do for acute limb ischemia? So medical management alone in the form of anticoagulation can be sufficient, especially for the very early forms of ischemia. So for the grade 1 and the grade 2A type of ischemias, medical management may be all that's required for certain patients, and we've seen this happening. In terms of surgical interventions that may be needed, we have access to either percutaneous endovascular procedures, and these can take the form of catheter-directed thrombolysis or CDT. Then also we can do percutaneous endovascular mechanical thrombectomies, and I will go into a little bit more detail on CDT and then to combine this with angioplasty plus minus stenting in the setting. open techniques which we use for acute lumischemias are mainly the Fogarty thromboembolectomy. I will discuss that also a bit, and then also endarterectomy and patch angioplasties or surgical bypass, or we use a hybrid technique where we combine an open procedure with an endovascular intervention. So when do you decide to do an intervention, and then what intervention does one then look at doing? So it's basically looking at a scale of two things, looking at the degree of ischemia. So what is the the urgency around the ischemia, and you have to balance that with the surgical risk of the patient. So this is just my take on how I look at this. A lot of people will do it differently, but I generally look at it from this aspect. So you look at the early ischemias, so the grade 1 and the grade 2A ischemias. Basically, these patients fall into a semi-urgent sort of category. And this is the ischemias that, patients that can still be admitted, have a CT scan, and maybe in the next 24 to 48 hours undergo an intervention if they need to. So these groups of patients also can either be managed only with anticoagulation alone, and we've seen patients who present like this, whose symptoms completely resolve just with anticoagulation, and you can use it in both fit and unfit patients. Catheter-directed thrombolysis can also be considered for this grade of ischemias. These are actually the ideal candidates for catheter-directed thrombolysis, and again, it can be used in both fit and unfit patients. So the grade 2B of ischemias, so these are the really very urgent patients. So these patients need to be in theater within 2 hours at least of having been admitted. And for these patients, there are these approaches that we can attempt. So we can try percutaneous pharmacomechanical thrombectomy, and I'll discuss that in a little bit more detail just now. And this can be used for both fit and unfit patients. Then also these patients, because you need to revascularize the limb urgently, they are also then candidates for open revascularization procedures or hybrid procedures. And these procedures can also be done in both fit and unfit patients. I said they except maybe surgical bypass in unfit patients, because it is a bit more of an invasive procedure. So one has to carefully look at the patient's surgical risk. The grade 3 patients, unfortunately, these are the group of patients who have non-salvageable limbs, and unfortunately, they need a primary amputation. And this has to sort of happen in a relatively urgent period. Also, I said for the very sick patient, one may have to sometimes consider palliative measures and palliative care. If patients are extremely sick, from a cardiac perspective, especially, we see this sometimes, and often one has to make the decision that maybe less is more for these patients, and you know, palliating them may be the more you know, appropriate management for them. So just to discuss a bit about catheter-directed thrombolysis. So the medication that we commonly use is actylase, which is a recombinant human tissue plasminogen activator. It has a relatively short half-life of 5 to 10 minutes. So therefore, when one does catheter-directed thrombolysis, it has to be given as an infusion through a catheter. And it works by directly activating the plasminogen on the thrombus and activating the plasmin within the plasminogen, which then causes lysis of the fibrin strands, and thus causes lysis of the thrombus. We normally give a bolus dose of 5 to 10 milligrams intraarterial initially, and then we do an infusion through the thrombolytic catheter at a rate of about 0.05 to 0.1 milligrams per kilograms per hour. And then in that time, the patient is monitored in a high care or an ICU setting, and you know, you monitor the lymph perfusion in that time, look for any complications such as bleeding that can be associated with thrombolysis. And then after a period which is quite variable, can vary from 12 to even 24 hours, depending on your rate of infusion, you then take the patient back to theater or cath lab to do a repeat angiography. So this is just a pictorial diagram just to show how we do the catheter-directed thrombolysis. So we do an ultrasound-guided arterial puncture. So, for example, this is the femoral artery that you're looking at. There's a thrombus in the proximal superficial femoral artery, and we do an ultrasound-guided access of the common femoral artery, and then we place a working sheath into the common femoral artery. And then under angiographic guidance, you identify where the thrombus is, you pass a guide wire through the thrombus, and then over the guide wire, you put the thrombolysis catheter. And the thrombolysis catheter is placed into the thrombus to just distal in the thrombus. So the idea is that over that period of thrombolysis, the thrombolytic gets dispersed through the sidles of the thrombolysis catheter into the thrombus, and that is where the thrombolytic has its best action, from within the thrombus. It causes activation of plasmin in the thrombus, which leads to effective breakdown of your clot. So this is again just showing the mechanism of the TPA activating your plasminogen to plasmin, the plasmin which causes breakdown, lysis of your fibrin strands, and then causing gradual breakdown of your thrombus buildup. There you see the sidles, the thrombolytic being infused through the sidles of the thrombolytic catheter. So, as with most things, there are contraindications, and catheter-directed thrombolysis certainly is the one type of therapy where one has to be very, very aware of bleeding, especially. TPA is a very, very active agent, and it can cause quite a severe systemic bleeding. So the contraindications to using thrombolytic therapy would be anyone who has had a current or a previous intracranial hemorrhage, anyone with an intracranial tumor, an intracranial AVM or an intracranial aneurysm, anyone that has active internal bleeding, anyone that has had a stroke within 3 months, or who has had intracranial, intraspinal, or intraocular surgery within 3 months, and anyone that has had major surgery within the past month. And then also anyone that is known with a bleeding tendency. And then also look out for patients with severe liver and or renal dysfunction. Pregnancy is also a contraindication, and also one has to be very, very careful of using thrombolytic therapy in patients with an increased age. Also, patients with very high blood pressures, one should be careful of using thrombolytic therapy. So this is the other form of revascularization that we have. And in our setting, probably this is, the form of revascularization that we probably use, I'd say, in about 70 to 75% of our patients. It's called the Fogarty thromboembolectomy. And as the name implies, it was invented by that gentleman there, Thomas Fogarty, who was an American cardiovascular surgeon. And he actually got the idea for the Fogarty embolectomy catheter from a transurethral catheter. So that's where he got the idea of the Fogarty catheter. So you can see the link between urologists and vascular surgeons dealing with pipes and fluids and catheters. So, so the Fogarty embolectomy remains quite an effective and a minimal access form of revascularization for quite a lot of patients. And there are two forms of catheters. We have the conventional catheters, which are placed directly into the artery through the thrombus. And then we have the other one, which is called an over-the-wire Fogarty, where the catheter goes over a wire similar to the one that you use to place a thrombolytic catheter. And the advantage of the over-the-wire is that you can steer the Fogarty catheter into various arteries that you need to extract thrombus from. So I'll show you an example of such a case later on. So basically, that's the principle of a Fogarty catheter. It's done through a groin incision. You identify the femoral artery in the groin and isolate the inflow and the outflow from the common femoral artery, and do an arteriotomy over the distal aspect of the artery. And then the Fogarty catheter is inserted through the thrombus. The bulb of the catheter is then inflated with saline or crust. Then the thrombus is then physically extracted by pulling on the catheter and then physically pulling the thrombus out of the artery. And you can see there those chunks of thrombus. So you can see how imaging is important in these cases. So you can then, under imaging guidance, place the Fogarty into the thrombus and extract the thrombus out of the artery under imaging guidance. So this is one of the mechanical or percutaneous mechanical thrombectomy devices that we have available in South Africa. It's called the Aspiration device, and it works percutaneously, and I'll show a short video just now of how the animation video of how the device works. So what the catheter has in the tip of the catheter, it has a spiral, stainless steel spiral that is mounted on a wire, and this wire is then connected to a special drive machine, and the catheter is connected onto this motor, and the motor then spins at a very high frequency, and that sets up an aspiration force inside the artery, which then creates almost like a vacuum effect inside the artery, and it literally then pulls the thrombus from inside the artery, pulls it into the catheter, and then the thrombus is lysed as it is pulled into this catheter by the spiral. I'll show a short video on, I hope I can get it to run, on how the catheter works. See if it will play. Sorry, the videos are not playing. Sorry, I can't seem to get that video to play. I'll try and move on with the presentation rather. So the other percutaneous thrombectomy device that we have available in South Africa is called the angiojet, and the angiojet is basically what we call a rheolytic pharmacomechanical thrombectomy device. So what it also does is it basically the device injects jets of saline or thrombolytic medication at high velocity into the catheter, and it also then sets up a very low pressure in the in and around the catheter tip, and this then also causes the thrombus to be sucked into the catheter, and then as you see there, it's drawn out into the catheter into a collection bag. So this is one of the other percutaneous devices that we have available. So the videos are not working. I can't get into play. I'm sorry about that. Of course, everything has its complications, and acute lumischemia, as well as treatment, has its fair share of complications. The most notable ones being compartment syndrome, and this can arise from the muscle being ischemic for a prolonged period of time. So we see it in patients that present with delayed ischemia. It can also arise post or after revascularization. Reperfusion syndrome is also a complication that we are quite familiar with. These patients develop rhabdomyolysis due to the breakdown and flushing, systemic flushing of the degraded muscle tissue. They can also, as a result of that, develop hypokalemias, cardiac arrhythmias, and also acute tubular necrosis with renal failure. And as a result of the renal failure, they can, develop metabolic acidosis. Bleeding, as we discussed earlier, is also a problem, and it's mainly due to the use of anticoagulants and thrombolytic medication. So, compartment syndrome, the way to treat compartment syndrome is a 4-compartment fasciotomy, and the goals for doing this is to assess, number one, assess the viability of the muscle tissue, and then also to relieve the muscle compartment pressures. So there are 2 settings to do fasciotomies. One is a preemptive setting. So we sometimes do this in patients that have very delayed presentations. And then the emergent setting, where patients either present with compartment syndromes or develop compartment syndromes subsequent to the revascularization. Reperfusion syndrome. So here the mainstay of treatment is IV fluid resuscitation. Obviously, one has to bear the patient's cardiac functional status in mind. You can't obviously overload a patient who is in cardiac failure. So one has to use the fluid resuscitation based on that. Intraoperatively, the anesthetist should be aware that one, will be reperfusing potentially ischemic muscle, and then they have to have their measures in place to treat any consequences thereof. So they either preload the patients with fluid, they have their drugs available to shift potassium, so Act Rapid, dextrose water, calcium carbonate. They can try to reverse acidosis with sodium bicarbonate. But for those patients who have refractory hypokalemias or refractory acidosis, one should first reassess the viability of the muscle. If the muscles are not viable, those patients may then need unfortunately may then require an amputation. Otherwise, if the muscles are still viable, they may need treatment with hemodialysis. So they may need urgent hemodialysis. Bleeding is always a concern, especially in patients who are on thrombolytic therapy. So we look at those parameters to indicate, that we probably need to stop this patient's anticoagulants or their thrombolytic therapy. Also useful to check the coagulation profile and if you have access to it, to the thromboelastogram to guide the administration of blood or the blood products. So these are just some cases that I'm going to run through. This was a patient that we managed at SK last year. Is a gentleman that presented with acute ischemia after, while in hospital with a COVID pneumonia. You can see there on his angiogram, he had a cutoff of his very distal popliteal artery. Fortunately for him, he had collateral vessels reconstituting distal flow, and we managed to treat this patient. You can see there we had a thrombolytic catheter in him, and you can see he had a good result with just thrombolytic therapy. And we also did an angioplasty of that small area of stenosis in that anterior tibial vessel. These are just some other cases. This is an example of a Fogarty thromboembolectomy of a brachial artery. You can see there cut down over the brachial artery in the cubital fossa, in the Fogarty effectively extracting thrombus from the brachial artery. This is a similar case that was described. Patient also elderly patient with atrial fibrillation that presented with acute ischemia of her left arm. And you can see there on her imaging, she had a cutoff of a brachial artery, and she responded quite well. As you can see, they described the 36 hours of alteplase infusion, and this was a result after just thrombolytic therapy.
Dr. Russel, you still have a few more slides.
Yeah, I'm about to finish.
Okay, sure.
Just wanted to show you, this was a case where one could use the steerable Fogarty embolectomy. So you direct the Fogarty into those vessels, and you're able to extract the thrombus as indicated there using the steerable Fogarty embolectomy catheters. So thrombosed popliteal aneurysm. You can see there, this is a posterior approach on the popliteal fossa. You can see the popliteal aneurysm, your gastrocnemius muscle heads extracted, and the aneurysm, and endarterectomy, and the patch plasty with the vein patch done. Thank you. So in summary, acute lumischemia is a surgical emergency that often goes under-recognized, and yet, if one can identify this group of patients early, it can both be limb, and or life saving for these patients. I think one of the big things we need to also have a look at, and what is needed, is that one needs to create public and patient awareness of the condition. Also, we know these patients have a high comorbidity profile. They tend to be vasculopaths, underlying cardiac conditions, COPD, renal failure. Those are by far the majority of patients we see. presenting with acute ischemia. Also important, one needs to have good discussion with the patient and with the patient's family as to how one is going to proceed further with managing their ischemia. As I said, effective treatments are available, and often they are multimodal treatments. Thrombolysis combined with angioplasty, or thrombolysis combined with bypass. So it tends to be multimodal treatments that are needed for these patients. As we said, also imaging is very important. It's central to the effective management of these patients. And in South Africa, we face still challenges, a lot of challenges with these patients. Distances, to the few dedicated centers where these patients can be treated effectively are still a problem. Transport is still a problem. So sometimes for certain cases, one needs to be pragmatic. If you are at, a hospital where, you have a patient with, a grade 2B ischemia, and, you're going to have trouble to get that patient to a referral center within 6 hours. If there is a surgeon at that hospital, one then has to make a decision. They can attempt, embolectomies there and refer the patient on following that if needed. So effective communication is needed. So, in such a situation, call a friend, pick up a phone, get advice, and, these patients, their outcomes can be improved. Thank you.
Oh, thank you very much, Dr. Du Toit. Awesome. Quite an informative discussion. Shows a lot of passion what you're doing. Practical examples of how to manage this acute limb ischemia. And I see that you're also still at work this time. See lots of people moving behind you there. There is one question sent to me directly. I don't have any other questions. We thought we'd have more time for discussions, but not much time is left now. Does prolonged smoking also cause acute limb ischemia, or is it more a chronic and a gradual onset type of a problem?
Yeah, so that's an excellent question. So we know that smoking is one of the most common reversible risk factors for peripheral arterial disease that we encounter. So it definitely tends to be associated more with chronic disease, but as I pointed out, the thrombosis that occurs in these patients happens in the arteries that have extensive underlying already atherosclerosis, and then they have a sudden thrombotic event, as in someone that has a heart attack. You get a sudden plaque rupture and occlusion of the artery, and that is how these patients present, with these acute ischemias. So it definitely is a risk factor for both chronic and acute on chronic limb ischemia.
Thanks for the response. The second question is, when a patient suffering with cramps while asleep, what causes this phenomenon? And also, I think related to that question is then the patient complains of discoloration of the limbs. I think this, part of that was left out.
Yeah, so especially if a patient has those type of symptoms, one would have to think about the patient having underlying peripheral arterial disease, with cramping at rest especially, or the classical description of these patients are having severe burning in the feet while they're at rest, and it often wakes them up at night. So one would have to think about the patient having underlying chronic limb-threatening ischemia and investigate them accordingly, you know. Obviously, there are various other causes for cramps and so on. It could be, you know, metabolite disturbances, but I think one, you know, if on clinical assessment you don't feel a foot pulse, think about, you know, underlying chronic limb-threatening ischemia and investigate them, you know, accordingly.
Okay, thank you very much. These are the only two questions that you have. I don't know if there's anyone else who has a question. If you've got a question, you can either post it on the chat or through the last 2 minutes left. If you have anybody's got a burning question for Dr. Du Toit, just to check. Thank you. It's almost time for, because we normally finish at about 7:30. And I see that you're still at work. You might be having a case to, one last more case to manage this evening. But I just want to thank you very much, Dr. Du Toit, for taking your time and also spending so much time to prepare this presentation and give us more information about how to manage the acute limb ischemia, which is quite a big problem. And that's, you know, giving us the different settings where when you can salvage the limb and when you cannot salvage the limb, and who needs to assist here. And you're currently working at Dr. SK Matseke, where you can be found to manage any patient, any colleague who's got a case that they need to refer urgently. They may contact you. And thanks for this time. We really appreciate the quite number of people who say that thanks for the presentation, quite informative, comprehensive presentation that you managed. And I just want to thank also the colleagues who joined us, who've been with us every week, joining us. I just got a comment to say that they find this presentation is quite informative. Even for people who are not in clinical practice, it quite helps a lot just to know what's happening out there. And thank you. And we also want to thank Zuki, who's with us this evening, the background, helping us and showing us what happens at some of our facilities. And so to make sure that we have a smooth presentation every week together with the team for marketing. And to say on behalf of Clinics Health Club, we just want to thank everyone for joining us this evening, and we hope to see you back next week. We're having another discussion on cardiovascular issues. We're having a presentation by Professor Joe Vereva, who will be speaking on hypertensive emergencies. So we hope that you will join us. We'll be sending out the link, the invitations by close of business tomorrow, hopefully. And we hope to see you back again. Thank you and have a good evening.
Thank you. Thank you.
Thanks, Doc. Thanks, everybody.